first lecture today is brought to us by Drs. Lili and Komal Bajaj. Dr. Komal Bajaj is the Chief Quality Officer of New York City Health and Hospital Jacobi North Central Bronx. She's also a Clinical Director for New York City Health and Hospital Simulation Center. She co-chairs the Systems Monitoring and Evaluation Subcommittee for its Equity and Access Council. Dr. Bajaj is a president of obstetrics and gynecology at Albert Einstein College of Medicine. She's an innovator based in New York City, catalyzing quality and safety transformation across all facets of healthcare delivery. She was appointed to the AHRQ National Advisory Council in 2022. Dr. Bajaj is an internationally recognized expert on ingraining equity into quality and safety, and the use of simulation and debriefing to advance healthcare quality and safety. Her scholarly interests include integrating equity into quality safety structures, defining approaches to embed simulation within the clinical environment, developing solutions to address diagnostic safety events that contribute to maternal mortality, and characterizing the emergency role of debriefing in healthcare quality and safety. That is a lot. Dr. Lili is a clinical associate professor in the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine. She is board certified in both maternal fetal medicine as well as obstetrics and gynecology. She received her medical degree from the University of California, Irvine in 2008 and completed her residency, hold up one second, sorry, completed her residency at the University of Southern California, LAC plus USC Medical Center in 2012. She completed fellowship in maternal fetal medicine at the University of California, Irvine College of Medicine in 2016. Let's give a warm welcome, Drs. Y and Bajaj.
Thank you so much, Melissa, and for the rest of the organizers. It's really a delight for both Lili and I to be here with you today. Our apologies for not being able to be there in person, hopefully next time. And I think that, I was just sort of reflecting this morning on the millions of dots that have to connect for all of us to sort of be together today. I just want to honor the efforts that we are all making to improve maternal and child care. As Melissa so graciously highlighted our bios, this work is also represents the work of Miss Ariel DeRoche, who's one of our research assistants, and then Dr. Dina Goffman from Columbia University. Here are our disclosures. Melissa mentioned most of them, and all of these relationships have been mitigated. So, today we have really, I hope a thought-provoking discussion with all of you. We're going to explore the National Academy's Diagnostic Safety Framework and its application to obstetrics. Think about some of our own, sort of journey in applying a diagnostic safety lens to our own maternal morbidity and mortality reduction work, and then really provide some concrete strategies and ask all of you, whether you're, answering via chat or whether you are in an auditorium, what is one concrete action that you can take away from this discussion today? There's a lot of resources that we'll be sharing. And rather than you feel, one, this talk is recorded, but also at the end, we will have a QR code with all of the resources that are discussed. And so if you see this little icon on any slide, it means that there's an associated resource with that discussion. As we sort of are going through this, certainly if someone had asked me, well, what do you know about diagnostic safety 5 or 6 years ago, even as an OBGYN and quality and safety leader, I would have said not that much. And we will be exploring some of our, own stories. And again, we're going to be asking each of you to think about your own environments. And we just want to honor that all of us here, all of us are gathered here today to sort of do better. And that we want to improve. And at the end of the day, right, we really can, we can and we must do better for those birthing persons that we care for. And I don't need to remind this audience of the really the gut punch every single time new data comes out. It's heading in the wrong direction, and certainly heading in the wrong direction. And continues to remain a challenge where we see disparities play out day after day. This is some new data from the Commonwealth Fund, which sort of demonstrates, the United States and its maternal mortality rates compared to, other countries. And again, as we sort of look at the spread of conditions, right, this will vary by slightly by populations or year after year, but clearly cardiovascular, sepsis, cardiomyopathy, hemorrhage, pulmonary or other embolism continue to be really important causes. As now Lili and I both take care of patients clinically as well as our quality and safety work. And I've started, this is a post from my LinkedIn account that got a lot of attention. I've started to, when I meet patients, really acknowledge the elephant in the room when they're sort of reading and seeing things in the media. I find acknowledging this public health crisis really has resulted in better trust and partnership, and constantly striving, just as we all are, to think about, well, how can we do better? Because at the end of the day, the vast majority of maternal mortalities, as we know, are preventable. But thankfully, not all is lost, right? All of us have seen, sort of seedlings of success. All of us have had sort of initiatives where we have seen improvements in our processes, in our culture. And so as we're talking about a diagnostic safety lens, we're not saying that people should stop doing what they're doing, or sort of, it's about sort of really thinking about how do we integrate all of this safety science from other fields of medicine into the work that we're doing. And so to honor that there are so many efforts that are underway, I would love to see if people could throw into the chat. And Melissa, there is no chat, or I noticed it's a Q&A, so.
That is correct.
Okay.
Let's see if we can, let's practice. Let's see what happens when we look at
Victoria Gordon.
We can see it. Way to go.
Yeah, cardiac. So, so keep going with that. I'd really urge folks to put into the sort of Q&A. What's one strategy that you have been participating in, that you have read about, that has been, sort of has seen promising results? So Victoria has mentioned cardiac screening on admission. Let's see if anything else comes through. AIM bundles, absolutely. Thank you for that. So there's a lot of work in progress. And so again, we're going to be asking you to really think about, well, how do we apply a diagnostic safety lens to some of that work? Reviewing data with teams for awareness. What a powerful thing, right? To loop back with the staff that are sort of doing those efforts. Thank you. So a little bit about sort of our definitions for today, because, it's interesting when you talk to those that are sort of, who champion the field of diagnostic safety now, 20 years ago, the first president of the Society for Improving Diagnosis in Medicine, he acknowledges that it's a little bit of a word salad. And so what we're going to be talking about today when it relates to diagnostic safety is accurate and timely identification of a patient's health problem, or and effective communication of that health problem. And that comes from the national academies. And then, sort of related to that is diagnostic error, where a diagnosis is missed, wrong, or delayed. And certainly those are words that, through our maternal mortality review committees, we have often heard, right, as a cause of maternal death. I'm going to turn it over to Dr. Way to tell us a little bit about the scope of this problem.
Great, thank you so much. So we know that most of us will experience a diagnostic error sometime in our lifetime. Every year, about 1 in 20 people will experience some form of diagnostic safety error, about half of those being potentially harmful. So we know that this is a problem that we're going to see. Next slide. What's not known so much is the impact of diagnostic error in obstetrics. It's a relatively new concept. And so there aren't that many studies that have actually looked at the frequency of diagnostic error in obstetrics, but I do want to kind of give a couple of examples of small studies that have looked at this. in one review that really took a look at these adverse events in obstetrics, we found that about 30% of them were due to communication errors, 31% due to kind of clinical performance, but about 18% were due to diagnostic errors. So it is something that's there. We just don't know that much about it. And this is why this work becomes really critical. Next slide. So we know it remains under study. There's limited data on its occurrence and its impact on maternal and neonatal outcomes. So we can definitely do better in this area. Next slide. Kind of adding a little bit more to the information that's out there. In one kind of small study, they looked at this, and in pregnant women, it was 3 times more likely to cause complications. And in another study that came out from an academic center, what they did is they kind of looked at these adverse events, errors without injury, and potential adverse events. And the most frequently reported events involved either a delayed diagnosis, which was 39% of the time, or really delayed treatment, which was 31% of the time as well. Next slide. So what does this tell us is that, we know maternal mortalities are preventable 80% of the time. So what we really need to do is focus in on this area and use our diagnostic error tools to work on preventing them. Next slide. So the focus really of our area that we're going to, work on is obstetric hemorrhage. And I want to kind of go into postpartum hemorrhage and give a little bit of information. So we know that the definition everyone here knows, but really cumulative blood loss of greater than 1,000 or blood loss accompanied by hypovolemia within 24 hours of vaginal or cesarean delivery. We know it's a leading cause of maternal death worldwide, as well as even in the United States. Next slide. So as Komal mentioned earlier, we have, all of these resources will be given to you at the end, but I just wanted to kind of put out some of the key resources that are available on obstetric hemorrhage. We have the National Partnership of Maternal Safety from ACOG, the obstetric checklist as well for hemorrhage from ACOG. The CMQCC, was one of the places that really started a lot of these hemorrhage bundles and toolkits that we have. And I know on the Georgia Perinatal Quality Collaborative website, you guys also have some similar toolkits available, but I wanted to just put these out there. I'm not going to go through them in detail, but we have them available at the end. Next slide. So really just focusing on these bundle updates that came out from AIM in 2022. Now really it's 5 R's, and what we want to do is really focus in on how obstetric hemorrhage applies to each of these R's. Next slide. So the package change, really focusing on what are some of the concepts and, things that you can do within each of these areas, whether it's response, readiness. Those are all kind of laid out for, can we go to the next slide actually? Yeah, so for readiness, within obstetric hemorrhage, what can every unit do? And we sort of have these laid out, whether it's, working with a team that's on, with recognition and prevention, communicating with, the team when you think that there's a hemorrhage, response, doing, unit simulations and being really ready to respond to hemorrhage. And then really having a good reporting system in place for when you do have a hemorrhage. And finally, the added R of equitable care and really focusing on where the gaps are in that. Next slide. These are just some of the existing stage-based OB hemorrhage emergency management plans that I just wanted to put out there. One of the ones on the right is what I mentioned earlier from ACOG. We know there's obstetric hemorrhage checklist that could be utilized. And this is really on the left, the color system for stage-based hemorrhage. And I think it's very useful. Next slide. So this is a really important algorithm for the diagnostic process. And what we're really going to focus in on is the red area in the middle, looking at, clinical history, physical exam, diagnostic testing, and referral and consultation as it applies to obstetric hemorrhage. And I know Komal will go into this algorithm a bit later in more detail. Next slide. So now focusing really in on the middle, how can we apply this diagnostic process specifically to obstetric hemorrhage? So for clinical history and, really focusing in on risk factors for hemorrhage beforehand. On the physical exam, obviously, we know recognizing signs and looking at vital signs, critical, inspecting for lacerations, really checking the uterus for retained products of conception. And then for diagnostic testing, being on top of labs, ordering them serially. And then for referral and consultation, really having in place a hemorrhage protocol, additional assistance being called specialists as needed. Next slide. All right, so I'm going to turn it back over to Komal to really focus in on the diagnostic process.
Thanks, Lily. So, we're using obstetric hemorrhage as an example, and really hoped to, sort of provoke your thinking around how does the diagnostic process, the diagnostic journey for each of our patients, really play out, whether it's hemorrhage, whether it's cardiovascular conditions, really any example. And we all know that the diagnostic process itself is dynamic and very team-based. And there's uncertainty and it plays out over time. And of course, we're not just talking about when someone comes in labor, but ideally this coordination of care, this unfolding of, sort of the diagnosis in the antenatal period is equally as crucial, I should say, really across the continuum into postpartum as well. And so, this is the National Academy's sort of framework on a diagnostic process, as Lily outlined. And what's really important is, well, we have tools, we have checklists, we have all sorts of documents and policies that tell us what to do, right, in each of these areas. And yet we see over and over again, whether it's hemorrhage or other diagnoses, that it doesn't play out that way, right? And so we have to think about, well, here's this pretty scripted diagnostic process. What is the interplay of the diagnostic process and the work system, right? Which is composed of the team members, the tasks, the tools. By organization, we mean culture and environment, right? Obviously, all of these play a really crucial role to that diagnostic process, sort of working. And so recognizing that, there's a lot that has been written through the national academies, there's a lot that has been studied within sort of specific fields of medicine, including internal medicine and radiology, recognizing that people, sort of birthing persons die because of delay in diagnosis or escalation. We really wanted to explore what is the contribution of diagnostic error to maternal morbidity and mortality, and really set out, sort of a robust research agenda. Very fortunate to be able to do this work with the Agency of Healthcare Research and Quality. So here are some of the, sort of potential opportunities for research, right? One, just sort of thinking about those person-centered communication best practices, whether it's explaining uncertainty itself, right, which is often a challenge, or certainly during an emergency or during a critical situation, how is the diagnostic process unfolding? I think there's a lot of opportunity there. Looking at strategies to identify and mitigate bias. Think about, and I see that this was mentioned in the chat, what is the right secret sauce of risk assessments? And if a risk assessment is flagged, right, how do you make sure that that clinical intervention happens? Develop standardized approaches to training, think about the role of simulation, and think about how our EHRs either promote, right, or mitigate diagnostic error, right? So for example, in the case of hemorrhage, someone is flagged to have anemia. How do we make sure they get to the right place at the right time for treatment long before their delivery? And so in an effort to begin to advance this research agenda in collaboration with the National Academy of Medicine and the Council of Medical Specialty Societies, we embarked upon a study in 2021 to really begin to understand, well, what is the nature of diagnostic error during maternal hemorrhage care? So we're not talking about the ones that we see in a review committee, right? These are the sort of events that are happening long before there is harm, right? Long before there's harm. And so we developed an observation tool. We validated that observation tool, applied it to a large series of simulated hemorrhage events, and then are in the process of sort of the next phases of developing a toolkit based on those events. And so I mentioned simulation, so I have to just sort of honor and acknowledge that our simulation program serves all 5 boroughs of New York City and the needs of our entire health system, which is the largest municipal health system in the country. And while I recognize that a lot of folks don't have, a simulation program that is of that sort of scale, we hope to share this as an example of how you might think about characterizing events in your environment, simulated or not. And so again, we wanted to develop an observation tool. And so we didn't want to, really recreate the wheel. So we took existing tools, the SAFER DX instrument, the AIM hemorrhage team debriefing form, a patient toolkit from the Society of Improving Diagnosis in Medicine, and the CMQCC hemorrhage toolkit. And so here, the SAFER DX instrument, which I found to be really, really rich, provides guidance on how an observer can cognitively deconstruct the diagnostic process. So through a series of sort of questions, right, promotes discussion around the diagnostic process as it unfolds. And it really provided the foundation, the diagnostic safety foundation for the rest of the tools. The hemorrhage debriefing form, I suspect many are familiar with, which is organized by the 5 R's. And what we drew from this form was the idea of met, not met, recognizing that met and not met are going to be locally defined. This toolkit gives me tremendous joy. It's a patient's toolkit, which includes guidance for patients to engage with their care provider about their diagnostic process. And then the CMQCC toolkit, which was, sort of revised in April of 2022. So we began to sort of look at the SAFER DX framework and then link the variety of sort of actions and, debriefing prompts throughout each of those other 3 resources. We refined the observation tool, met with some content experts, and then iteratively refined the tool based on feedback. And we made changes to both the structure, utility, as well as content. So here is a screenshot of that tool, right? And so you can see here, this is an example, right? Met, not met. And what's key here is that not only do you have event observations, sort of things that are happening during the event, but also debriefing, right? Which is really the sauce. You can look at a chart, you can talk to people, in the days after an event, but to be able to catch their reflections right after an event is really important when it comes to, well, why did things go well? Or why did things not go as planned? And so we piloted this tool using the same standardized scenario across the entire health system. So we deployed about 230 in situ simulations. And you can sort of see here, it was a spontaneous vaginal delivery where the patient begins to have symptoms and had an initial blood loss of 450. So observers were looking at these events, looking at the critical actions that are involved in the diagnostic process, making observations about why things might have gone well or not well, and then captured debriefing observations from the participants themselves. And we used the framework theory because we really wanted to look at this qualitative data. And so this is a schematic that shows all of those critical actions across the first 11 simulations. And so what I want to sort of take a moment to really talk about is the hemorrhage cart in the room. What you can see here is that we were looking at the interplay of that diagnostic process and how did the work system affect the ability to have a hemorrhage cart in the room. And we came up with some really interesting results. So hemorrhage cart in the room, right? Lots of policies, many of our own, your facilities talk about sort of some sort of hemorrhage, cart in the room or a to-go bag. And in the cases where it was not met, there were actually 3 very different reasons as to why it wasn't met. The first related to tasks. Someone knew to get it, but they got called to do something else and they left it in the hallway. Another was, related to the tools itself. There were no hemorrhage carts in one facility. And as a result, even though it was a critical action that's key in the diagnostic process, couldn't get it. And then the physical environment. We were doing simulations in the ED as well as on postpartum units. And we discovered that there was no hemorrhage cart on the postpartum unit. So all of a sudden you can see here, if you were reviewing a chart or you were looking at an EHR dashboard, what you would see would be a large blood loss, and you might see, transfusion or additional escalations. But when you begin to really look at the root causes of why things happen, you never discover why a hemorrhage, whether the hemorrhage cart was in the room, right? Or whether, and the reasons why it wasn't in the room. And so here are a few sort of other examples. The diagnostic team members were really open to say, you know what, we didn't communicate with the patient because we were fixated on the task, right? That's something that's happened to me, right? And they were very generous in sharing that. When it came to sort of tasks and specifically TXA, which is a relatively newer addition to our algorithms, many people said, well, we think of it, it's not a uterotonic, but we sort of pair it in our minds with the uterotonics because we think about it as first line. And that was their sort of mental trigger to make that happen for them. And then the physical environment, clearly having a scale near where the hemorrhage is occurring promotes quantitative blood loss. So we've completed all of those observations. We have several manuscripts in the works around, on the observation tool itself, as well as the observations that we made. And then we are working on developing graphics that clearly depict the diagnostic process. We feel like this will be valuable for other environments, not just labor and delivery. Begin to think about diagnostic safety related measures, which Lili will be talking about a little bit later. And then, really promote thinking around the diagnostic process through simulations and a diagnostic safety toolkit. So as we think about, how do you make this actionable, right? I hate going to talks where someone talks about their own work and then, well, how does this relate to me? And so we want to shift now from thinking about the diagnostic safety framework, an example of why diagnostic safety matters, to really think about, well, how do you apply these in your own organization? And the first is to review key diagnostic safety resources. And there are a bunch, right? There are a bunch. And I will say that, again, up until 5 years ago, I didn't know they existed. And now they're coming out fast and furious. The first is that toolkit that we mentioned to engage patients in diagnostic safety that comes from the AHRQ. Team Steps now has an extension that is specifically focused on diagnostic improvement. So a lot of folks will know the Team Steps framework, but there is now an extension specifically around diagnosis. The Safer DX checklist, which talks about sort of organizational practices for diagnostic excellence, and the Society Improved Diagnosis in Medicine is also a real wellspring for resources. The second is to engage local quality and safety stakeholders in diagnostic safety opportunities. We don't have to do this alone. And for this, I want to talk about a resource called Measure DX, which comes from the AHRQ. And it's a resource to identify, analyze, and learn from diagnostic safety events. What I'm heartened to see is that, there is really something about diagnostic safety for everyone. When it comes to sort of the board of trustees, they have a fiduciary responsibility to improve quality and safety, and sort of obviously that ties to reputation. For health entity resource, what I think has been really remarkable, certainly within our health system, is we have to think differently, right? The things that we're doing we've seen some changes, but clearly the data tells us we need to do more. And so it's new approaches, learning from different fields of medicine and apply them to OB. Patients have really sort of, again, there's a lot of patient-facing content around diagnosis. And we found that, patients are really sort of engaged and want to sort of help us with this work. From an IT standpoint, our dashboards are built to look at various events, and really beginning to add some of these diagnostic safety related measures may be a really important way to think about, well, how can I really think about, in the case of hemorrhage, for example, my referrals for anemia long before the hemorrhage occurs? Or, how do I look at when someone has one blood pressure in clinic, right, in the third trimester? How do I sort of navigate that to make sure that they get what they need? And so on and so forth. What I also think is really interesting is that diagnosis is often seen in, as sort of a diagnostic safety or diagnostic excellence curriculum for trainees. not just physicians, but nurses, PAs, et cetera. And so, you know, they're familiar oftentimes with this language as well. Another key part of this resource is an organizational self-assessment. And I won't go through all the details, but if you look at this resource, it will sort of go over, you know, sort of and prompt you to think about, you know, your organization within these 5 buckets. And the point here is that you can't do it all, right? It's hard to say, well, we're now going to shift resources or to do anything in the era that we live in. But again, there may be 1 or 2 things that you can begin to tackle to apply a diagnostic safety lens to the work that you're doing. The third is to develop capacity for diagnostic safety work. And I want to highlight 3 important fellowships in diagnostic excellence. The first is from the Society to Improve Diagnosis in Medicine. The second is the National Academy of Medicine Scholars in Diagnostic Excellence. And then the IHI, the Institute for Healthcare Improvement, recently launched the Gordon and Betty Moore Foundation Scholarship. So two full year-long program, two fellowships, which are part-time, mostly asynchronous, and span 1 year. I also want to mention that the National Academies will be hosting a workshop on advancing diagnostic excellence for maternal health care. You know, anytime the National Academies takes on something, it clearly is because there's a need and it elevates the conversation around the topic. I'm honored to be part of the planning committee for this workshop. It's on July 27th. It's free. You can join in person or virtually, and the link will be in the QR code. But we haven't yet announced the full speaker agenda, but I have to say, like, I am so excited and wowed by sort of folks, including celebrities, that we've been able to secure for this event. I'm going to turn it over to Dr. Wei to talk about selecting diagnostic safety measurement strategies.
Great, thank you so much. So now what we want to really focus in on is, so we talked about, you know, preparing your organization, doing kind of an organizational self-assessment, but what are some of those measurement strategies that you can utilize from your data? So next slide. And next slide. Yeah. And so what I want to focus in on is, you know, we have sort of these general concepts, but how can you make this more OB specific? And so that's what I want to focus on. So the first part for this measure diagnosis is really using quality and patient safety data that is already collected. We have a lot of data from, you know, cases referred to risk management, morbidity, mortality conferences, resolve claims, and really focusing in on those in order to be able to, you know, kind of collect your data. So OB specific examples being, you know, we all run quality reviews, RCAs, and so really focusing in on those ones for your data. Severe maternal morbidity reviews, whatever is set in your hospital, whether it's ICU admission, to determine preventability. Next slide. And then really another area is looking at your data, soliciting reports from clinicians and staff. So for OB specific examples, really having a safety event reporting system with OB specific triggers for reporting. Everyone, you know, should have their own system in place for that, but really also learning from debriefings of obstetric emergencies, whether it's for, you know, hypertension or postpartum hemorrhage. Next slide. And then also using really patient-reported data. You know, we know for OB-specific cases, for example, patient reporting system with specific entries on respectful care at birth. We all look at patient-reported experience measures, and even things like Facebook or, you know, mom groups and social media pregnancy groups. A lot of information can be obtained from that. Next slide. And really using your electronic health record to your advantage. Some of those examples with an OB being completing a postpartum hemorrhage risk assessment at appropriate time points during labor. So at our hospital system at NYU, we do one upon admission to labor and delivery, and then after a certain period of time during the labor course, we complete it again. So really having that in place within your electronic healthcare system. And then quantitative blood loss documentation and really having that ingrained into the system. appropriate stage-based postpartum intervention, so postpartum hemorrhage intervention. So this would be once there is a postpartum hemorrhage, kind of really documenting that. Next slide. All right, so the next, what I want to focus on is, giving a really concrete example of what you can do in your own health system, whether it's on a system level or an individual level. And what I want to focus in on is this tool called Calibrate Diagnosis. So this is a tool that came out actually last year from AHRQ. It's a resource to really improve diagnostic decisions. Next slide. And what this is really the purpose of the tool is to provide clinicians with some guidance for evaluating and calibrating their diagnostic performance for really learning and also improvement. And what it includes is that there are several parts to this Calibrate Diagnosis. The first part of it, if you end up opening it and really going into detail, it gives you an introduction to what this exercise is. Part 2 tells you some specifics of the task. Part 3 will give you guidance on evaluating diagnostic performance. And really part 4 is for planning and applying improvement strategies. And I'm going to go into this in a little bit in more detail. Next slide. So this is kind of looking at it on a bigger picture. So what does it include, the Calibrate Diagnosis? Well, it's a self-evaluation exercise. You kind of take some time to evaluate a case. You pick cases to review, and then you really partner with who you're going to review these cases with. So next slide. What this is a revised, this is from this tool, the Calibrate Diagnosis, and really it's an instrument where you go through, let's say you pick some cases and you really give yourself a score in terms of whether things were met or not. So, and then once you have the score, you really can utilize this to study the cases that you've picked. And I'm gonna show that in a second here. Next slide. So here for specifying the calibration task, what you do is you really choose an area of practice for which you want to be better calibrated. You want to get better in this area. For evaluation, you select a small sample of those cases specific to the calibration task at hand. And then for plan and apply, you really identify some improvement strategies for yourself and your team, and then you start to take those appropriate actions. And then the fourth part of it is really reflection. Well, now that you've done this, you've planned, you've applied, how can you really study if this is working or not? And I'm going to look at this now on an obstetric level. So what I want to show you is, how can you do this in an obstetrics, framework? So on an individual level, so for myself, I do a lot of outpatient work. So as a maternal fetal medicine specialist, so I'm not always on labor and delivery, but what can I do specific to this Calibrate Diagnosis tool? Well, on an individual level, I can, for example, specify that I want to just improve my diagnosis of anemia in my patients. As Komal mentioned, one of the first parts is identifying anemia, correcting it before you have a hemorrhage, because that way the patient's set up for hopefully not needing as much if there is a hemorrhage. So what I do is, this is my area I want to improve on, and then I really will go through and I evaluate, I pick cases and look at opportunities where this was missed during my care as a provider. And so, and I look at the reasons why. So one of the, we have a very diverse patient population here in Brooklyn. And so did I use the correct language to communicate with the patient the severity of their anemia? And did they understand this? And is this why maybe they didn't understand it? And this is why they did not go to their hematology appointment or set up the iron infusions. And I evaluate, do I have a system in place for referring patients appropriately to hematology and starting IV infusion? So this is on an individual level, something that I can evaluate. And then I plan and I apply. And so I identify a way to monitor once I have a system in place. Well, am I doing this now? What is my solution? So I connect with a hematologist, and I'm actually doing this here. So it's a good example. We connect with a hematologist, we make quick referrals. And so I set the patients up for iron infusion, and that's my plan and apply. And then really reflecting on this is taking a sample of the cases periodically and seeing if this workflow is functioning appropriately. And am I detecting anemia better now than what I was doing before? Next slide. Others may not, necessarily be working on a, outpatient setting, and more so on a system level. So we can also do the same thing with the Calibrate diagnosis, apply it on a system level. So the task we're going to specify is, well, there's sometimes a delay. Obviously, we know there's a delay in diagnosing postpartum hemorrhage. So this is the task that we want to calibrate, evaluating it. So I randomly select 10 cases from the electronic health system for vaginal delivery greater than 1,000 and cesarean over 1,500. And I look at, was blood loss quantified for these cases? So that is one area that I can evaluate. And then when I go to plan and apply, I'll co-create a workflow to really ensure the blood loss calculator is readily available. So if that was a reason why it wasn't calculated, was it because it wasn't available? Providing, provider training periodically to make sure they're utilizing the quantified blood loss appropriately. Obviously, there's always new providers coming onto the floor, and we want to make sure that that's being done. And then really reflecting on any changes that I make, I would debrief the first 5 hemorrhage cases that are incorporating my new workflow, and really seeing the process that's in place now. And furthermore, even like just randomly selecting cases on a quarterly basis to see if this workflow that was implemented is being followed. So these are just 2 examples. You can, apply various examples to this on both individual and system level. Next slide. All right, I'm going to have Komal take it back.
Thank you so much, Lili, for that, sort of walkthrough, and I think that, as I'm sort of looking at the examples that you provided, both for the measures and also for, Calibrate DX, I'm really heartened by, oftentimes we look to see, sort of the outcome, and obviously we need to take a look at all of those cases. But we can begin to look a lot more upstream, right? And look at the diagnostic process long before someone's birth journey begins. I'm thinking about my sort of own environment, across our health system, and thinking about, well, those antepartum admissions, or those visits to the ER where there's either referrals made or where there are labs that are still pending at the time of either their discharge or their, discharge from the ED. And, beginning to think about, well, are those areas sort of ripe for diagnostic safety analysis? Because as we sort of think about those populations or those events, it's likely that those are areas to be missed. So thank you for that, review. So we'd like to prompt each of you, and if, unfortunately, if we were in person, I would have loved for each of you to sort of turn to your neighbor, turn to folks around you. As we sort of outlined some strategies today, we really want to prompt you to consider, what is one concrete action that you can take towards applying a diagnostic safety lens to your own organization? And that we'll put those sort of strategies up again. And maybe Melissa, now I'd love to sort of prompt anyone to sort of throw into the chat or Q&A, what's on their mind as they sort of think about this discussion, or really open it up to any questions that folks might have before we move to close. So first, let's see, is anyone willing to share what's one concrete action that they are thinking about applying in their own environment based on this discussion? Thanks, Chris, for sharing. Co-create a process to analyze and learn from diagnostic safety events. Chris, would you be willing to either go off mute or maybe share sort of, what might be your first step to do that? Or even just type into the chat what might be your sort of first step to do that. And Mary Lou is sharing this information with the hospital medical quality team. I really appreciate that. I have to say, diagnostic safety has not been within the lexicon of women's health quality and safety folks. And it's certainly been a learning curve for all of us who have been in this space. But I'm hopeful that, through some of the work that, we've presented this at IHI several times. The IHI actually invited us to present this again at the Safety Congress in May. Through the National Academy work, I'm hopeful that we're beginning to have sort of the seedlings of attention and then funding announcements as a result. So Victoria has asked, we do chart reviews, but really aligning it with an actual tool. Wonderful to hear that. I think a key step for us as a community of practice going forward will be, each state in its review committee, even sort of beginning to ask questions with a diagnostic safety lens, I think will take us one step further. And certainly, chart audits locally, I think, is a really important step. Anyone else willing to share? Great. So Chris is in the process of working with system level quality team to ensure we have a standardized process of conducting RCAs that focus on SMM. Wonderful. Bringing facility-based results to the system level to identify any opportunities. That's awesome. And if, I think that that's a really, rich, unfortunately too many, right? But a rich place to start. And I wonder, as you begin to sort of unpeel the layers, that you'll start to take a look at, those events where thankfully there is no severe harm, but there were sort of clear opportunities for the diagnostic process. One of the things that I'm really sort of excited about is really thinking about, this idea of, incomplete referrals, this idea of labs that, sort of don't get followed up on in a timely fashion. I think these are going to be really rich areas for us to move forward on, again, long before the diagnostic process unfolds during a birth. Anyone have any questions? Or anyone else willing to throw anything into the chat? All right, we will move forward. So, as we're sort of thinking about this collectively, we can and must do better. And part of that is going to be thinking differently about the diagnostic process. And we'd really love for you to keep the conversation going. We're all sort of available. And I really hope that some of you will be able to join the National Academy workshop, even virtually in July. This is our QR code that sort of explores the resources that were discussed today. We'll give a moment for you to sort of snag that. And Melissa, I'm going to turn it back to you.
Awesome.